Hello, everybody. Welcome to one of the first meetings in National Thrombosis Week. What a program we have for you. And this session is no exception to the exemplary quality of the speakers around thrombosis. So this is a particularly important session. It's learning in obstetrics and gynaecological thrombosis. And we have three great speakers covering very topical issues. So let's get started. I'm really delighted to introduce Dr. Kenneth Hodson, who's a consultant in obstetrics and maternal medicine at the Royal Victoria Infirmary in Newcastle. He's also head of UK Teratology Information Services. And in the COVID pandemic, he has been working with all the authorities, looking at the collection of data related to the use of the COVID-19 vaccines in pregnancy. So he couldn't be better than anybody else. He is better than anyone else to talk to us about vaccination in pregnancy, safety monitoring, and other considerations. So Ken, over to you. Really looking forward to your talk. Thank you.
Thank you very much. And thank you very much for inviting me to speak today. Let's move my windows down. So I thought I would just give a brief a summary really of how COVID-19 has affected pregnant women. And the message really is that most pregnant women will just have mild symptoms from COVID. Most of them will not become unwell. However, a small proportion will become unwell. And of these, they do become quite seriously unwell. So about 30% require extra oxygen and CPAP, 10% will require ITU. There's approximately 1% mortality rate. If you look at this study, you can see that pregnant women with COVID versus pregnant women without COVID, there's almost 100-fold increase in the need for intensive care in pregnant women, and pregnant women are 3 times more likely to have preterm delivery. And that often reflects the fact that pregnant women are sick with COVID and require delivery prior to going to intensive care. The UK Obstetric Surveillance Survey looked at cases of COVID in pregnancy overall, and at the time of publication was the largest series in the world, including 427 women. And what this study really identified was the risk factors for pregnant women with COVID. So you're more at risk of serious COVID, and by serious COVID we mean a hospital admission and or intensive care admission, if you are BAME or Black and Asian ethnic minority, almost a 4.5-fold increase in risk if you're older or if you have obesity. And you're also at increased risk if you have underlying medical conditions such as diabetes and hypertension. So approximately 56% of women admitted with COVID were either Black, Asian or ethnic minority, compared to 14% of the non-pregnant population. This timeline shows the development of the vaccines. And you can see it's been an incredible process, as most of you will realise that in December 2019 was the first cases of COVID were in the UK. Then we were in lockdown, and then the trials of the Pfizer-BioNTech vaccine began in April of 2020. And by November of that year, we had phase 3 trials that demonstrated effectiveness of the vaccine. And in the 7th of December, we were the first country to approve the Pfizer vaccine worldwide, shortly followed by the AstraZeneca vaccine and then the Moderna vaccine. So there are 3 vaccines currently in use. I just wanted to emphasize the difference between the vaccines, and this becomes more pertinent as I speak later on in my talk. But Pfizer and Moderna are mRNA vaccines. The mRNA is encapsulated in an oily nanoparticle, and those oily nanoparticles enter the cell and trick the cell into producing spike protein, which then gets presented to the immune system. The disadvantage of these vaccines is that they need to be kept at -70 degrees C because mRNA is susceptible to degradation quite quickly. Compared to the viral vector vaccines, so in the UK, this is the Oxford AstraZeneca vaccine, and in the States, Johnson & Johnson, which use a viral vector, a chimpanzee virus, which is a non-replicating virus. It's important to emphasize that, particularly when you're talking to pregnant women, that the virus doesn't replicate. It just acts as a vector to get the DNA into the host cells, and for that then to be expressed as spike protein and to stimulate the immune system. The advantage of the viral vector proteins, vaccines, are that their DNA is more stable. It's also protected by a viral coat and can be stored between 2 and 5 degrees C rather than -70 degrees C. And therefore, it's much easier to administer this type of vaccine in the community. The mechanism of action of the vaccines following both types of vaccine, the mRNA and also the viral vector vaccine, the vaccinated cell destructs and presents the spike protein to the immune system through T helper cells, and then you either get a B cell immune response producing antibody or a T cell mediated response creating T cell mediated immunity to COVID-19. Most of us know that the vaccines are efficacious, and these slides show the two Pfizer and AstraZeneca vaccine. The blue lines are placebo lines, and cumulative risk of contracting COVID is represented on the y-axis. The red line are the vaccinated patients, and you can see that after vaccination, very few of them contract COVID. And so efficacy for Pfizer-BioNTech is 95% after 2 doses, and efficacy of AstraZeneca about 82% after 2 doses. So which pregnant women can be vaccinated? Well, this has recently changed. So initially when the vaccines were approved for use, they weren't approved for use in pregnant women at all. And then on the 31st of December, the JCVI said that pregnant women in certain situations could be vaccinated. And the two situations that they said pregnant women could be vaccinated would be if they were high risk of exposure. So either they were healthcare and social care workers, for example, working in a nursing home, this JCVI group 2, or that they were high risk of contracting severe illness if they were to come across COVID or be infected with COVID, and that's the clinically extremely vulnerable group, group 4. However, things have changed, and the thing about the vaccination program is that things do change very quickly. And as of the 16th of April, so a couple of weeks ago, any pregnant woman can have the vaccine now in accordance with their age and clinical risk. And that's come from the Joint Committee on Vaccinations and Immunisation. So now any pregnant woman is eligible for vaccination. However, that's different to saying we're not actually going out to specifically target pregnant women. We're just saying that pregnancy isn't a sort of barrier to getting vaccinated if you were otherwise eligible for vaccination. So when we see patients in the antenatal clinic, what do we talk about? Well, we talk about the benefits of vaccination, protection against COVID-19, and the risk of contracting severe COVID is greatest in the 3rd trimester if you have other comorbidities, if you're obese, or if you're Black, Asian, or ethnic minority. And the benefit obviously is that it's 95% effective. This is for Pfizer. Now, there were no studies looking at efficacy. In fact, there's been no studies of the vaccines in pregnant women at all to date. There's about to be a Pfizer vaccine study, and I can talk about that in the questions at the end. However, none of the vaccines has specifically been tested for use in pregnant women. So we assume the efficacy in pregnancy is the same as that in the general population. And the other benefit is that it would reduce transmission of COVID to other vulnerable people in the family. What are the risks of vaccination? Well, vaccinations haven't been tested formally in pregnant women. There's no suggestion of any problem, however, with the vaccination in terms of animal data, no significant impact on fertility, the fetal anomaly rates, or pregnancy complications in animal models. And we have a lot of information about other non-live vaccines. So the obvious one being pertussis, which we give routinely to pregnant women, and influenza vaccine. And none of these non-live vaccines have been shown to be risky at all in pregnancy. However, there is very little human data. There is just been this study from New England Journal of Medicine. So this describes the US data of 827 completed pregnancies, all of them given the Pfizer vaccination. Out of 827 completed pregnancies, approximately 13.9, so 14% pregnancy loss rate, and 86.1% live birth rate. And this is comparable to the general population of pregnant women, similar levels of miscarriage and live birth rates. Preterm birth rates of women given the vaccine were 9.4% and small for gestational age 3.2%. Again, this is comparable to the background risk for these adverse events in the general population, and there were no neonatal deaths in the women given vaccine. So there were, however, several quite significant limitations to this study. This study is based on voluntary reporting, so women were given sort of an app to use and to report their own data. And they were also using a sort of like a yellow card, the US equivalent of the MHRA yellow card system, to gain data on the pregnancy outcome. Most of the vaccines were given in the third trimester, so the reported miscarriage rate doesn't necessarily represent a large proportion of women. So we need more information about first trimester exposure, and in particular first trimester exposure and congenital anomaly rates. The comparison is crude, it's unmatched controls, it's just a comparison with the background risk in the population. And it doesn't necessarily reflect the fact that these pregnant women probably were higher risk women being given the vaccine compared to the general population. Generally, there's underreporting of pregnancy and neonatal complications. The total number of vaccines given to pregnant women in the US is still unknown, and that obviously it's a very short-term study, so we only have outcome data with regard to whether there was a live birth and any immediate neonatal complications. We're yet to have data that is more long-term. And additionally, the first trimester exposure data, these patients haven't delivered yet, so we don't know what the outcome for those women exposed in the first trimester are yet. So although this study is touted to be evidence that the vaccines are safe, and certainly it doesn't show any safety concerns, I would take it with a pinch of salt that we don't have full data yet. When should we be vaccinating pregnant women? So this is a common question, and there's been no real advice from the JCVI with regard to this. As someone that does teratology, any new drug I would generally avoid, if you can, in the first trimester, just because there is a potential risk that it might cause a problem. Although, having said that, you have to weigh up the risk of not being vaccinated. And for certain pregnant women, for example, patients with severe cystic fibrosis or bad chest, it might be that the benefits of vaccination outweigh the risk. But from a pragmatic approach, I generally say vaccinate after 12 weeks if possible, unless the benefits outweigh the risks. And certainly you should be vaccinated before the third trimester when the risk of contracting severe COVID is greater. Initially, people said, well, if you got vaccinated, if you're a woman and you get vaccinated for COVID, then you need to wait for 2 months for kind of the vaccine to wash out your system or whatever. However, this is no longer advice. In fact, there is no evidence at all that vaccination affects your fertility, and there's been a lot of false reporting about vaccination affecting fertility and causing miscarriage, and this is all social media driven, but there is no evidence to say that vaccination affects your fertility. Initially, breastfeeding was also not recommended, but the JCVI have changed their opinion on that in line with the WHO and data from the US. And certainly there is some evidence that vaccinating pregnant women, that the antibodies cross the placenta and cross through breast milk and also confer some benefit and protection to the neonate. So does it matter which vaccine you get? Well, until recently, no. The JCVI didn't express a vaccine preference. So they said that any of the vaccines were adequate for use in pregnancy. They all have similar efficacy, and that AstraZeneca potentially easier to access due to the ability to store it between 2 and 5 degrees C. However, I know that you've all been talking about VITS this morning and this rare complication of vaccine-induced idiopathic thrombotic thrombocytopenia, which occurs very rarely following, mainly following the viral vector vaccines. The important message really about VIT in pregnancy is that just because you're prothrombotic, because you're pregnant, doesn't put you at increased risk of getting VIT from vaccines. And that's really is quite a difficult message for some people, and certainly obstetricians and midwives often ask, but surely pregnant women are more at risk of getting clots, surely they'd be more at risk of getting this complication VIT, but that actually isn't true. It's a message that we're trying to promote, that the vaccine doesn't increase your risk of VIT because you're pregnant. So the JCVI advice has recently been updated in April. So pregnant women should now be offered the COVID vaccination at the same time as the rest of the population based on their age and clinical risk. In addition, they say that based on US data, the JCVI advise that pregnant women should be given either Pfizer or Moderna vaccines. That's not because of the risk of VIT and the risk of thrombosis, but purely because of the pregnancy safety data that's been available from the US now. This has also caused a bit of an uproar in terms of women already being given AstraZeneca. What should they do in light of the JCVI advice that they should avoid AstraZeneca? But the advice is that if you've already had AstraZeneca, that you should complete the course of AstraZeneca, that it's not harmful to give AstraZeneca in pregnancy. It's just preferable, because we have more data, to give Pfizer or Moderna vaccination. What are we doing in the UK in terms of collecting safety data? And this has been a large amount of my work over the last 3 months. And the main amount of work has actually been to try and convince Public Health England, NHS England, and the equivalents in the devolved nations to start to collect data about whether women are pregnant or not. So it's taken us a couple of months to get them to add a field on to the NIMS system, which is the National Immunisation Management System, which is the computer system which collects all the data about your NHS number and your vaccination type, etc. As of last month, we've added a field to that system that says, are you or could you be pregnant? And we're going to use this data to collect information about pregnancy rates, number of pregnant women being given the vaccine, but also use the NHS number to link to the maternal and neonatal outcomes. And that's data that's routinely collected from any maternity unit, either through HES or the Maternity Services data set. And in doing this, we propose a weekly update, so we would know the number of women vaccinated, percentage of whom have delivered, and the percentage of whom had a healthy baby, and to screen for adverse events. And the main adverse events that we're interested in looking at are babies that are small, SGA babies, babies born preterm birth, stillbirths, and congenital anomaly rates. We need to then benchmark against matched cohorts. So I explained initially it was only high-risk women that have been offered the vaccine, and high-risk women often have higher rates of these adverse events. So it's really important when we do our data analysis that we match to cohorts of women that have not vaccinated but have the same kind of disease profile. And in this, produce a safety dashboard. And the other thing we were planning on doing, although probably now that COVID incidence is very low, it won't be necessary, but to link to positive swab results and to get some data about the efficacy of the vaccine in pregnancy. We did have to set up a temporary reporting system, which you may have been involved with, asking maternity units to report women who had been vaccinated in pregnancy. This is because it took such a long time for us to update the NIMS system, the computer system. But now this reporting system has now finished. We have collected data on about 380 pregnancies, and we're busy collecting the outcome data of the pregnancy as we speak. So in summary, the benefits of vaccination in pregnancy outweigh the small risks. For the baby, there's accumulating data from our own experience in other countries that the vaccination is safe. Maternal risk, the risk of thrombosis is very low, and the risk of thrombosis from COVID is much higher. So in terms of risk benefits, it's much better to be vaccinated for COVID. and protect yourself against COVID, but also against the thrombosis that is associated with COVID, not to worry about the VITS issue. We recommend following the JCVI advice, and the Green Book has recently been updated. An individualized discussion for those over the age of 30 with regard to risks and benefits of the different types of vaccine. And one of our main problem is trying to promote vaccine delivery and uptake. So up to now, it's been quite difficult to get pregnant women vaccinated. Pregnant women were turning up to vaccine centres and being turned away, for example. And we've done a lot of work with NHS England and Public Health England, and I know the same is true in the devolved nations, to try and improve vaccine delivery and uptake for pregnant women. I'll stop there, but happy to take any questions if there are any, or to take questions at the end.
Well, thank you very much, Ken. That's a really good summary of where we are. If anyone does have any questions, please pop them into the chat. That would be really helpful. So vaccinating women in pregnancy seemed to be a very special issue, but actually from all you said, it is no different than vaccinating somebody who's not pregnant. And do you think in the future, I'm just thinking of the flu vaccine as well, are we going to be continuing to vaccinate women in pregnancy and have a relaxed approach to it?
I think, vaccination, I think, is always a concern for people, and rightly so. I think that, it's right to be concerned that the vaccine might somehow affect the pregnancy, but all data that we have on almost all vaccines, even live vaccines, which do cause even more concern, none of them have shown that there is any harm from vaccination. And I think it's likely that the same will be true from the COVID-19 vaccination program. Obviously, we are collecting data, and that data collection is ongoing, and we will report our data. But it's been important to set up those safety systems to make sure that our assumptions are true. But I certainly think that the benefits of vaccination, particularly for pregnant women, particularly for diseases like influenza and COVID, where they can be more affected by those diseases, is very important.
Excellent. Where will we be in 5 years' time with vaccinating in pregnancy? Have you got a crystal ball?
I really hope that we are. It's been a major challenge, and I don't know whether my talk alluded to this, but it's been a major challenge just to get systems updated, to be able to get data, to be able to then establish safety. And I really, really hope that out of the whole COVID pandemic, that we now have this safety system set up. And I'm really excited about the data capture, because it encapsulates the whole of the UK population. So we have 100% ascertainment, which is very different from the studies from the US, which is all voluntary reported data. So I'm really hopeful that this kind of method of data collection and analysis of safety signals, not just for vaccination, but for other medications in pregnancy, will go forward as time progresses.
So it's the silver lining to a very dark cloud then.
It is, yeah.
Okay. Well, thank you very much. I think you made it so clear. It was wonderful. We will come back to you at the end, probably with some more questions.
Thank you.
It's time to move on now. So second speaker, another obstetrician, Dr. Jahnavi Daru. Jan and I have worked together for a number of years now. She's academic with a special interest in women's health. And she has in the past worked for the WHO in Geneva on antenatal care provision in low and middle income countries, and looked also at nutrition policies on iron deficiency. So during the pandemic, she has worked as part of the team out of the Royal College of Obstetricians and Gynaecologists, looking at the effect of COVID on thrombosis and pregnancy. And that's what she's going to talk to us about. So her title is Learning from COVID in Thrombosis and Pregnancy. Thank you, Jan.
Thank you so much, and thank you for inviting me to come and talk about this. I'm going to keep my presentation really short, because actually I think Dr. Hodgson's presentation was really interesting and more in keeping in the direction that we're going in. But nevertheless, let's crack on and see where we are. So just to make my disclosures really clear, I was a member of the COVID-19 guidance cell, which the RCOG created last year, basically in response to the pandemic and in an attempt to try and create some form of cohesion and trying to bring together the evidence base around COVID-19 and pregnancy and what we do and don't know. So what I'm going to talk about today is, trying to move my slides. I'm going to provide an overview of what we know about COVID-19 and the impact that it has on women and infants, the impact of thrombosis and being prothrombotic during pregnancy, and then adding in COVID into that mix. And then finally, I'll just quickly go over the thrombosis-related recommendations from the college, just as a bit of a recap for everyone that's listening to this talk. So what's the impact in general? Well, thankfully, the majority of pregnant women stay extremely well, more than 60%, and in certain instances, depending on the data sets that you look at, whether these are across the UK, the US, or in other nations, the vast majority of pregnant women stay completely well. And in the UK and in the US, we were in fact screening asymptomatic women when they came into labour and delivery to look for those women who were potentially positive and then barrier nurse them appropriately when they attended for labour and delivery. However, there is a risk of increased disease severity in women who are in the third trimester, have a raised BMI of more than 25, and have pre-pregnancy associated comorbidities, the most significant of which are pre-existing diabetes, gestational diabetes, and hypertension. In addition to, this is separate to the group of women who would be clinically extremely vulnerable, and I'm not going to spend a lot of my time talking about those because actually their disease process is very different. Women over the age of 35, again, more a higher risk of having significant adverse events related to COVID in pregnancy, and women from a Black and Asian minority ethnic group. Now, the data show that pregnant women are more likely to need intensive care admission, and actually it's quite unclear as to whether this is because the threshold at which pregnant women are admitted to the intensive care requiring ventilatory support is lower, or actually are they developing more severe disease. And this has been found in numerous studies, cross-section as well as cohort studies across the UK and in the US and Canada. And if you're looking at the rates of COVID in particular now, you would see that in Canada the rates are significantly higher, and there's a real significant maternal morbidity attached to this. The same wasn't really the case for us in our last round of severe disease. Women who are symptomatic are more likely to require birth by cesarean section. And again, this is due to numerous factors that it isn't clear whether these women actually have more severe disease or there are other cofactors contributing to this. What are the impacts of COVID-19 on the infant? Well, thankfully, there are very few. And as I've already mentioned, women with symptomatic infection are more at risk of having an iatrogenic preterm birth, and this would be both via cesarean section or via an induced vaginal delivery. And that's primarily in an attempt to try and improve their lung function. And there's varying case reports and systematic reviews that have looked to see, well, actually, is this causal? Is this related to the fact that they had more severe disease? And again, that hasn't been proven. There are documented cases of intrauterine transmission, however, they are very rare, and the RCOG actually advised that the risk of intrauterine transmission, including different modes of delivery, is very, very limited. So you're not at more risk of transmitting an infection to an infant if the woman delivers via cesarean section or via vaginal delivery. And again, there are data that are emerging that show that the risk of maternal infection in the postnatal period, so women who test positive for COVID-19 within the 6 weeks postnatally, the risk of transmission to infants for women who are breastfeeding, again, is minimal. So the advice is to ensure that if women choose to breastfeed, that they are encouraged and supported to do so, irrespective of their COVID status. So now to talk about thrombosis in pregnant women with COVID-19, and we've already mentioned, and the the group of individuals listening to this presentation are already very well versed in the fact that pregnancy is a hypercoagulable state, and adding in a COVID-19 infection, a transient infection, increases that risk. So the advice is to ensure that women are appropriately risk stratified in accordance to the existing Green Top guidelines. So the RCOG Green Top guideline number 37A, which devises a way of looking at the risk profile of a particular individual woman and determining whether she needs thromboprophylaxis or not. If women have severe COVID and they are admitted into hospital, whether they need oxygen support or anything more invasive, they should have low molecular weight heparin administered for the duration of their stay, irrespective of what their other risk factors are. And that's purely because we know that pregnant women who become unwell with COVID are prothrombotic beyond measure, essentially. And for those women with ongoing additional morbidity, consider extending that duration of thromboprophylaxis and have that discussion with the appropriate team, should you have that expertise where you work. So to go over the key recommendations, this is taken from the RCOG guidance document on managing COVID-19 in pregnancy, which was most recently updated in February of this year. So the advice is for women who test positive who are self-isolating at home, they are advised to stay well and hydrated. They should have a remote risk assessment performed in accordance to the existing guidelines, and consider that the infection with COVID-19 as a transient risk factor. So that's short term. It shouldn't mean that they need to take thromboprophylaxis for the duration of their pregnancy, particularly if they become unwell in the early stages of pregnancy. If women are already prescribed thromboprophylaxis for any of the other indications that they may have, that should continue if they test positive. And if there are concerns that a woman is actually developing an acute thrombotic episode during a period of self-isolation at home, then actually they need to have a clinical risk assessment done either in person or remotely to ensure that they have the appropriate prophylaxis and or treatment. And please ensure that local policies and procedures are followed to ensure that low molecular weight heparin is dispensed. Now, this is particularly relevant in the maternity population, because not all pregnant women will be seeing their healthcare professionals in a hospital setting. There may be some women who are low risk who receive all of their antenatal care within the community. And again, it's about ensuring that there's really good liaison systems between the different organizations to ensure that those women that need thromboprophylaxis do get it. So for women who are self-isolating and they have no other risk factors, that thromboprophylaxis should continue between 7 and 14 days. Again, if their mobility is limited and they have other additional risk factors persisting of symptoms, then again, seek advice from a trained professional who can help you. For women who are admitted, they should have low molecular weight heparin for the duration of their stay, unless imminent birth is anticipated. Now, this is important to consider for women who are self-isolating in the third trimester and require a low molecular weight heparin as thromboprophylaxis. Remember to say to them, actually, if they start to go into labor, they start to develop pain or any other symptoms, that they should then stop taking their thromboprophylaxis. This is to ensure that they can receive all of the available analgesic options when they come into labor and delivery. If you're looking after a woman with severe complications of thrombosis 19, so this is a woman that's headed towards intensive care or some other areas of support, that the dosing regimen for the type of thromboprophylaxis that you're administering is decided within a multidisciplinary team, which should include a senior obstetrician, an anaesthetist, and hopefully some VTE expert, ideally hematologist if you've got one, if not anyone else that's able to provide you the appropriate expertise to try and think through what the right dosing regimen should be. For hospitalized patients, they should continue the thromboprophylaxis while they're in hospital and for 10 days post-discharge. And again, consider extending this, particularly for women in the postnatal period, for whom we know that their thrombotic risk is at the absolute highest. And again, if you're unsure, seek advice. So I've just popped on a load of recommendations here and references, and I will make my slides available if they are, and I'm happy to take any questions, although I think it's probably better if they're directed towards somebody else. Thank you.
Thank you very much, Jan. And what we haven't got yet is any analysis of COVID in pregnant women, have we? Or is that paper being planned?
So, to my knowledge, there are studies ongoing looking at women who test positive for COVID and what their long-term sequelae are. And there's a few. Pan-COVID is just one that exists across the UK, and there's 3 or 4 others that are regional that are in existence. However, none of these data are published yet.
Okay, and I suppose the other issue is post-COVID condition or long COVID. Is there any evidence that if you're pregnant and you have COVID, you're more likely to have that type of problem?
Yeah, it's an interesting question. And again, the literature at the moment is pretty sparse on this. However, I anticipate that that will change. I mean, in my practice, I've definitely seen pregnant women who've had significant COVID that's required hospital admission, who've then gone on to have long-term kind of respiratory complications in particular is definitely there. So again, I think that these data will be emerging in the next few weeks to months.
Okay. And what do you think about the level of thromboprophylaxis in women with COVID?
Yeah, it's a double-edged sword, isn't it? I think the majority of people are very scared. Well, the majority of obstetricians and midwives, I can speak on their behalf, I hope, would be scared of a woman developing an acute VTE, particularly one that you could easily prevent with thromboprophylaxis. However, we don't really have the data to say that actually giving these short or long courses of low molecular weight heparin actually prevents a significant number of clots. That number needed to treat isn't there at the moment, and I think that means that a vast proportion of women are probably overtreated. However, I don't have the necessary data to back that up. This is anecdotal.
And you can understand that everyone is very anxious. If you've got something where you could hopefully prevent clots, then more people will get treated. But maybe with the data that will come through, we'll get some reassurance that the risks aren't particularly that much higher. Okay, I think I'm going to move on to the next speaker. Thank you very much. Come back to you in a minute. I'm really delighted to welcome Dr. Louise Newson, who's a GP and a menopause specialist. We have been talking to Louise. She runs a fantastic charity. She's the founder and a trustee for the Menopause charity, and is really committed to improving life for women with the menopause and getting evidence-based knowledge out there and making sure that healthcare professionals as well as patients are educated about what it's like being perimenopausal and menopausal. And she's also worked with HIV charities to help menopausal women with HIV. So Louise is really, really well qualified to talk about evidence and options in HRT and blood clots. Thank you again, Louise, for coming.
Oh, thank you. Thanks ever so much for inviting me. It's a real honour to be here on the first day of your very exciting week. And just to put things in context, really, my background is hospital medicine. Actually, I've got MRCP and then went into general practice. And now all I do, much to my family's annoyance, is talk about the menopause. So just a few declarations, really. I don't have any. I'm a director of a private clinic. We've worked out it's the biggest menopause clinic in the world, but it's private because none of me or the 36 GPs or nurses that work with me can get any job as a menopause specialist in the NHS, because the NHS do not at the moment see menopause as a priority. I'm also director of a not-for-profit company doing research and education in the menopause. And recently we've launched a free app called Balance. As very kindly said, I'm the founder of the Menopause charity, which is going to have a big launch in the next week or two, so watch this space. I do have one declaration in that I take HRT, and I'm very open to say that I would not be working as a doctor without it, because my brain had completely gone and I was really worried about how I was feeling without remembering anything. So I thought I would just start with a patient, actually. So this is a real patient. I've changed her name, but she's a 51-year-old lady. I've put that in bold because 51 is the average age of the menopause in the UK. So anyone who's that age should ring alarm bells, but actually women of any age can become menopausal. She came to see me because she generally felt unwell, more tired, less energy, bit of a heart sink patient for a Friday afternoon. Worst thing, migraines, and she'd had a long history of premenstrual migraines with aura. And she'd been seen in our local migraine clinic for about 9 months, and she'd been given some pretty toxic drugs, including pregabalin, topiramate, and gabapentin. And unsurprisingly, they'd all caused quite horrible side effects for her. She also had a history of recurrent urinary tract infections and lots of urinary symptoms. She had some urge and stress incontinence as well, getting some palpitations, which she worried about because she had a strong family history of cardiovascular disease. Her brother actually had dropped dead when he was 53 of a heart attack. So these palpitations really scared her. In her history also, she'd had a clot after a long flight 5 years previously, and she'd had a family history of clot as well, and she was known to have factor V Leiden deficiency. So I look at her notes thinking, let's see what's gone on. She'd had a plethora of blood tests. She'd had different urine tests. She'd had a CT scan of her renal tract, ultrasound, MRI of her brain because of her headaches. She'd had ECG echoes, 24-hour tapes because of her palpitations. Seen various specialists. All investigations were normal. No underlying cause found, which is reassuring, but not to her because she's experiencing real symptoms affecting her. Asking her a few more questions, more anxious, sleep not good. She was getting up in the night to pass urine, but also just because she was waking up. Irritable, low mood, some early warning awakening. So one of the doctors who had seen her before me had diagnosed a depression and given her citalopram. So because of thinking about the menopause, I just went straight for it and asked her when her last period was. And she said, well, it was 13 months ago. And she was getting some flushes, but she hadn't thought to tell anyone because it's just part of the menopause, which is just the natural process. So she was getting these hot flushes and night sweats. Also, I'm quite direct in my consultation, and I asked her about any symptoms related to vaginal dryness, of which she did have. And a lot of her urine infections were postcoital. Her last smear, she said, was really uncomfortable and very painful, and the nurse just said, don't worry, you don't need to have it very often, but didn't give her any advice or treatments. She said her libido was on the floor, but it didn't matter because last time was so painful. So now it's pretty obvious, I hope, that it's menopause, and a lot of these symptoms, probably all of them actually, were related to her low hormone levels. So the real question as a practitioner is, should she have HRT or not? The question is, she's got migraine and she's got a history of clot as well. So there's a big group of women across the world who the immediate reaction would be no. So I'm here to try and tell you differently. Just thinking about the menopause, it's really important. Menopausal women like myself are here to stay and pester, so they need to be listened to. The average age of the menopause, as I already said, is 51. But often, hopefully, we'll live for 30 years. So many women, it's longer if they have an earlier menopause. So that means a third of our lives we're postmenopausal with low hormone levels. So rather than thinking of it as something that just happens to middle-aged women and they're a bit annoying, it actually needs to be thought of as a female hormone deficiency syndrome with significant health risks. So obviously all women are affected, but indirectly you could argue men are as well. And we know the majority of women have symptoms, but a lot of their symptoms are not being picked up or recognised. Research has shown a quarter have severe symptoms, but I think it depends how you define severe. There's a lot of women, around 20% of women actually give up their job as a consequence of some of their symptoms. Because it's a natural process for most of us, a lot of women don't go and see their doctor, even despite their symptoms being worse than they expected. And this is a survey I did with West Midlands Police, showing that the majority of women actually didn't realise their symptoms were due to the menopause until they were given information, which is really important. We need to remember that estrogen affects every single cell in our body. And even talking about COVID is very important because it is an immune regulator. And there's definitely estrogen is behind some of this gender difference with COVID. Every single cell in our body responds to estrogen. And that's why it's so important to have in our bodies as living women. There's a myriad of symptoms, some of them I've spoken to already. This is a poster actually we put on the back of West Midlands Police toilets for all women. And one lady said to me, do you know what, every time I go to the toilet, I feel sad because I am that meno lady and I don't know how to get help. So my clinic's really busy, not because of flushes and sweats. These are the symptoms that really floor women and really affect their ability to work and function as a woman. And in fact, even in the clinic every week, we see extras who are suicidal as a direct effect of their low hormone levels. But for me as a physician, I'm not just interested in helping women feel better. I'm really interested in the risks related to the menopause. And we know that without these hormones affecting every cell in our body, there's risks of osteoporosis. 1 in 2 postmenopausal women will develop osteoporosis. Cardiovascular disease, risk of heart attack increases by a factor of 5 after the menopause, type 2 diabetes, obesity, cognitive decline and early dementia and depression as well. So clearly menopause should be seen as an opportunity because even in a 10-minute consultation as a GP, I can pretty much turn around someone's life and make them feel better, but actually invest in them so they've got preventative health care as well. Women need to know more information. There's lots of information that I provide completely free of charge on my Menopause Doctor website and also with the Balance app as well. It's not a biochemical diagnosis, and that's what makes it very difficult. But women can usually diagnose it themselves with the right tools. And we use a menopause symptom questionnaire and ask women to fill it out. And if these symptoms occur with a change in periods or stopping their periods, then you've probably made the diagnosis. So there are good guidelines that we need to work out of. The NICE menopause guidance now 5.5 years old, and sadly they're still not implemented fully throughout. And the International Menopause Society guidelines came out a year later, and again, they're really good and comprehensive. So just to summarize the guidelines, individualized care is really important. We need to let women know about the benefits as well as any risks of HRT so they can be make a shared decision-making process regarding treatment. And all the guidelines are very clear that for the majority of women, the benefits of taking HRT outweigh any risks. Women can take it forever. There's no maximum length of time. You wouldn't stop someone who had an underactive thyroid gland, their thyroxine, and the estrogen needs to be thought of the same. Obviously, it's not just taking HRT. We need to think about our lifestyle as well. But shockingly, in the UK, actually, we're doing one of the best in the world for women taking HRT, but it's only around 12%. So the majority of women are not taking something that would benefit from. So looking at the benefits, clearly it improves symptoms if you get the dose and type right, because you're simply replacing like for like, you're replacing that deficit. So symptoms will improve. But it also reduces the risk of all the conditions that increase without it, which are really important. And I'm sure has a big role with COVID severity and mortality as well. And there is some evidence that women who take HRT are nearly 80% less likely to die from COVID compared to women not taking HRT. So as a doctor or a healthcare professional who can prescribe, if you try and prescribe HRT, it will warn you. It will warn you to use it for the lowest dose, the shortest length of time. And obviously today we're talking about clot, and it really will scare me as a doctor because it's saying, careful, careful, clot. And this is regardless of any type of HRT that I try and prescribe. So there's no wonder that doctors and healthcare professionals are really scared of HRT. So if we think of clot in women, we all know that the incidence increases with age, and menopausal women are more likely to be older, I've already said. There are other risk factors, clearly, including a past history of a clot, obesity, some of the inherited conditions, and we know oral contraceptives are not a good combination if someone's had a clot or at risk of clot. So we know that oral HRT, so that's oral estrogen, is contraindicated in women with these risk factors. It would be silly to increase risk further by giving them something that increases risk of clot. So if we look at HRT, there are different types and doses. I've already said there's an increased risk. Now, it's a small increased risk of clot in women that don't have risk factors, but it's still a risk that you don't particularly want to take if there are safe alternatives. Most studies usually quote it as a double increased risk, and the risk is highest in the first year of taking oral HRT. Obviously, the risk is still lower compared to being pregnant, for example. But if we look at transdermal estrogen, there is no increased risk. So the odds ratio 0.9. Actually, I think there probably is some reduction risk, the way that estradiol affects our endothelial cells, and it also improves production of nitric oxide. So it's probably anti-thrombogenic rather than pro-thrombogenic. Vaginal estrogens, which only work locally, but they can be transformational for a lot of women. There's no systemic absorption, so therefore there's no clot risk, regardless of what the person's history is. And also there's no risk in general, so women who've had breast cancer can clearly safely use vaginal estrogen preparations. So if you look at the difference between oral and transdermal estrogen, the way that oral estrogen leads to high levels of estrogen concentration in the liver, it obviously has to be digested, it has to be metabolized, it can impair protein synthesis, so it induces hypercoagulability. Also leads to a reduction in antithrombin 3 levels. There's an activation of the coagulation cascade when it's taken orally, and it also induces a resistance to activated protein C. So even very low doses of tablet estrogen has these effects on clotting. There are different types of oral estrogen, but the conjugated equine estrogens, we don't prescribe them many more, but they're the ones derived from pregnant horses' urine, and estradiol, which is synthetic as a tablet, they all have a prothrombotic effect. So there's quite a few trials now confirming that, and you'll see that the risk increases. The WHI study is the study that came out in 2002, which was the big nail in the coffin for HRT. And this shows that estrogen alone, the relative risk was 1.3. Estrogen and a progesterone, they used MPA, a synthetic progesterone, increased risk even more. And actually, when you look at older women, unsurprisingly, that risk was even greater. So this is just another study, the ESTHER study, estrogens and thromboembolism risk study, and it's showing MHT, which is menopause hormonal treatment, so the same as HRT, transdermal, again, just going slightly below that line, which I think is actually really interesting, but oral quite a lot up. So this was quite a key paper really that came out in the BMJ in 2018, but the MHRA still haven't updated any information about it yet. And this was looking at 2 nested case control studies, and they used UK primary care research databases, and they adjusted for confounding factors. Looked at a significant number of women, over 80,000 women, who aged between 40 and 79 who developed blood clots. And they found, unsurprisingly, that HRT tablets was associated with a higher VT risk. Again, the risk is still low, 9 extra cases per 10,000 women per year. So this is just a table from the paper, and you can see here that transdermal estradiol, that risk 1.05, depending on BMI. But interestingly, the women with a BMI between 25 and 30 was 0.87, so again, a lower risk of clot. You'll see higher up in the table that when it's conjugated equine estrogen with the medroxyprogesterone acetate, which was what's used in WHI, that's where it increases more, and unsurprisingly, the risk increases more if women are more overweight. So that's reassuring, really, that there was no increased risk of clots with transdermal preparations. Sadly, the day this study came out, all the newspapers did was say HRT risk of clot, and they just pulled it all together and then worried women even more about oral HRT. We also know there's not good studies, but the studies that there are looking at people with established clot risk. So there was a study with giving transdermal estrogen women with factor V Leiden mutations. There was no significant increased risk of clot in these women, whereas the risk obviously was so much more, so 25-fold with oral estrogen. So that's really reassuring, certainly to a lot of my patients who do have an increased risk of clot. So the optimal HRT, whether a woman's got a clot or not, in my mind, is transdermal estrogen with a natural micronized progesterone. And this is just a paper that I wrote for the British Journal of General Practice a couple of years ago. There's an easy HRT prescribing guide on my Menopause doctor website, which is referenced. The transdermal estrogen, as some of you hopefully know, comes as patches, gels or spray, all available on the NHS. There's no risk of clot, so it can be safely used with women with a history of a clot. The NICE guidance say that if a woman has an increased risk of clot, refer to a haematologist. Sadly, a lot of haematologists don't know much about HRT, so it's actually wasting their time and also wasting the women's time as well. Also, interestingly, oral estrogen increases sex hormone binding globulin, so reduces freely available testosterone and can reduce libido further. Transdermal estrogen doesn't have this effect. So the NICE guidance say we should consider transdermal estrogen for women who are obese or have diabetes, migraine, gallbladder, liver problems. But actually, I use it first line. I have very few women who take oral estrogen because it's so convenient and it doesn't interact with any other medication. So it's body identical. It's derived from the yam plant. These are the ones that are available in the UK, and it's about giving women a choice. Some like patches, some like the gel and the spray now as well. Younger women, so around 1 in 100 women under the age of 40 have an early menopause, premature ovarian insufficiency. And so these women, to match physiological levels, often need much higher doses. So sometimes they need 2 100 microgram patches or maybe 8 or 10 pumps of gel a day. And that's quite safe. And again, it doesn't increase risk of clot. So it's not just estrogen that's the bad guy, though. We need to think about progesterone versus progestogens. I already showed you with the WHI study that adding in a progestogen actually increases clot risk. And progestogens are really quite nasty. They're in the contraceptive pills, but there's a choice with HRT, and we should be thinking about the natural body identical progesterone. All these others are synthetic, and they affect not just clot risk, but they affect the mineralocorticoid receptors. Some of them are spironolactone derivatives. They're more likely to cause side effects. They also have a cardiovascular risk as well as a clot risk, and they can raise blood pressure and cholesterol as well. So we know that the risk of clot increases by about 50% in women who use estrogen with progestogens compared to estrogen only. Women who've had a hysterectomy can have estrogen only, but if women have a womb, they have to have a progestogen or progesterone to protect the lining of their womb. So obviously the progestogens vary, but in my book, they're all quite nasty. So the micronized progesterone is micronized. That means it's gone to a very, very small particle size and put in oil so it can be actually absorbed orally. And it's an exact duplicate of the progesterone produced by us. So this means that women are less likely to get side effects, which is obviously really good, but also it has different metabolic effects in the body. So obviously, I've already said that micronized progesterone doesn't increase risk of clot, which is really, really important. In addition, it doesn't have a cardiovascular risk. It doesn't affect lipids. It actually, some studies have shown that it will lower blood pressure, so it won't increase. And interestingly, everyone's worried about the breast cancer risk, which has never actually been proven, even with the synthetic progestogens. The risk with the WHI was not statistically significant. But in recent meta-analysis has shown women who take micronized progesterone with estrogen, there's no increased risk of breast cancer for the first 5 years. And after this time, it's not even been shown to be significant. There's actually any type of HRT, there's a lower mortality from breast cancer in women taking HRT. So one of the frustrations, I have a lot of frustrations in my job, is that micronized progesterone is still not widely available. Some CCGs don't have it in their prescribing formulary, and it's not widely available in Scotland, but it's dirt cheap. It costs around £4 a month for the NHS. So we prescribe Gestan, which is in the UK, the micronized progesterone, either continuous, it's actually licensed 25 out of 28 days, but we give it every night, or cyclically, it's just 2 at night for 2 out of 4 weeks. It's a slight sedative, but many women like that as a side effect because I've already explained some women don't sleep very well. Can be used vaginally at half the dose, which is off license, but that still provides endometrial protection. The Mirena contains a synthetic progesterone, but because there's not any systemic absorption, a lot of women find it really useful, especially if they want contraception. And I'm sure most hematologists would agree it would be safe in women who've had a clot risk in the past. Just to mention very briefly, it's now called GSM rather than vulvovaginal atrophy. If you look up the word atrophy, it's wasting or withering away, and none of us want to do that. So they've changed it to include the urinary symptoms as well. And it affects around 80% of women after the menopause, yet only around 8% of women receive treatment. And obviously it can cause all sorts of symptoms, but it's not just symptoms in women who are sexually active. I see a lot of women here in my clinic who can't sit down, they can't wear underclothes, even walking is uncomfortable, yet they've never had treatment. And it progresses over time. Hot flushes may improve after a few years or a decade or so, but these symptoms won't. This is a consensus statement I've recently written in conjunction with the British Society of Sexual Medicine, which just really goes through about treatment. And there are lots of local treatments, but they're not HRT, despite what the insert says. We can safely give them to as many women as possible. There's very, very few contraindications. Around a fifth of women who take systemic HRT still need to use localized treatment, so it's fine. So these are absolutely fine for women who have a risk of clot or have had a clot in the past. Just to let you know, on the patient information, we've recently written a booklet. It's under the resources section of my Menopause Doctor website called Menopause and Clots, and it's been a real honour to do that in conjunction with Thrombosis UK and have Beverly and some of the team just to go through it. It's the only booklet that we've actually referenced for patients as well. We've put some references in because it's really important for them to understand where the information that we're giving them has come from. One of our patients has got antiphospholipid syndrome, and she's written about her story on the website as well. And I think that's really important for people to just acknowledge and understand what some of these women go through when they're denied HRT. So going back to Claire, the lady at the beginning, excuse me, when I saw her in the clinic, clearly she was menopausal. I wanted to help her. I gave her patches because patches often have a more constant delivery, which is good for people with migraines, because migraines can be triggered by this fluctuating estradiol levels. Gave her continuous progesterone and also some localized estrogen, and offered her some non-hormonal local products as well. 3 months later, her migraines were better. She felt much better. She said, I've regained my energy levels and joined a gym. I can actually go through the day without feeling like I'm going to fall over with exhaustion. And certainly the medicine I do in my clinic is very transformational. It's just frustrating listening to the stories of women who are suffering. So take-home messages: individualized care, not just for the menopause, everything we do in medicine, but the menopause can lead to many different symptoms. So everyone should be aware of it, especially because of the health risks associated with the menopause. And there are more benefits than risks for the majority of women. And most types of HRT are safe, even to women who've had a clot. And that's really important. Evidence-based information clearly is very crucial. Just to let you know, I have produced a remote educational program available for women, for all healthcare professionals, and we've used actresses to act out different scenarios so people can see really how to help women and prescribe HRT safely. So thank you very much. I know that's been quite quick, but I hope it's reassured people out there. So thank you.
Well, thank you very much, Louise. That's very comprehensive and so lovely to have such an informative lecture. You're there, you're at the front line, you're doing practice in general practice, as well as having all this information. Can we just reiterate the fact that those with thrombotic risk who aren't on anticoagulation really ought to go for transdermal? And then I have quite a lot of people who are on long-term anticoagulation, and I don't see the problem with them using oral HRT. Do you have any comments on that?
No, but I don't see the point of having oral HRT really. So even women, regardless of their history, I try and convert them onto transdermal, because most women, as I've said, can take it lifelong. And there certainly is this evidence that certainly if they're on oral, then it's going to be a synthetic progesterone, and I just don't like them. The more I read about them, I worry about the cardiovascular risk actually more than anything else.
So is the quality of life any different between the transdermal and tablets?
No, I think it's probably slightly better. And I say that for two reasons. Firstly, a lot of progesterogens can just cause a bit of moodiness, a bit of weight gain, fluid retention. But also women can be more in control when they have transdermal. Certainly when they use the gel, they can sort of tailor it a bit to them. So if they feel slightly worse, they can increase the dose. So they can just be a bit more flexible, and women actually like that. I also think the way transdermal doesn't affect the sex hormone binding globulin can actually allow women to just often they find their libido and their energy returns a bit more actually when they have transdermal.
And is it last year there was a shortage of transdermal? There was some problem with the glue. Do you know
Yeah,
much
that was
about that?
part of it. I was cheekily excited because there was an increased demand. So, but one of the companies that made one of the patches has been taken over by another company, and there's no problem now with it. So, so it's not a problem. If there are chemists that are saying that it's because they're not used to their own demand in the chemist, but actually regionally or nationally, it's absolutely fine.
Okay, and there's a specific question for you from Claire Gibson. Would you be kind enough to recap on transdermal HRT and breast cancer risk? Thank you.
Yeah, so it's not just transdermal and oral. We know from WHI study that women who have estrogen only HRT, so women who had a hysterectomy, actually had a 25% lower risk of breast cancer. Came out last year, so 18-year follow-up. Obviously didn't go to the headlines, but that's really significant actually. Then adding in the synthetic progesterone, then there's this narrative, is there an increased risk? When you look at the data, it's not statistically significant, but there might be a small increased risk with synthetic progesterogens. If you add in the micronized progesterone, there's no study show there's an increased risk. But when you compare the risk, even if you look at the worst study with the worst risk, that increased risk of breast cancer is less than the risk a woman has if she drinks a couple of glasses of wine a night, she doesn't exercise, or if she's overweight, because these modifiable risk factors are still risk factors for breast cancer. A lot of women who take HRT lose weight, exercise more, drink less wine as well. So it's looking at the bigger picture. But also, every study that's looked at breast cancer mortality, even with combined HRT, have shown there's a lower risk of mortality. We know that estrogen used to be a treatment for breast cancer. So even women who've had breast cancer, often they choose to take HRT too. So it's a lot more research needs to be done, but it's safe, basically, is what I'm trying to say.
And then there's a question from somebody called Hanny. Why do transdermal HRTs not increase DVT and cardiovascular risk while tablets do?
Well, that's what I explained in one of the slides about how it's affecting the metabolism and the clotting factor released by the liver. Because they've bypassed the liver, you rub it on your skin or stick it onto your skin and it just goes straight through to the bloodstream. With oral estrogen, it's thought that it has a different effect on the endothelial function, but also that's looking at the WHI study. Average age of women in that study was 64, and a lot of those women had cardiovascular disease already. So you're giving an oral estrogen and a synthetic progesterone to women with a diseased endothelium. Very different to us giving women HRT starting in this window of opportunity when they're under 60, within 10 years of their menopause, when their endothelium isn't diseased. And so then it's very anti-inflammatory on the endothelium and very protective for cardiovascular system.
Excellent. I'm going to ask the other speakers to join you. Jan, Ken, you put your lights on if you're available. And just to really open the discussion, So what we've heard today is from the three of you in very specialized areas, where one of the issues is that there is probably very poor health education out there, both the healthcare professionals and also of the public. How are we going to improve health education for women about all these issues? I know it makes I don't know the answer, which is why I'm asking.
I'm very happy to answer. I mean,
Please, yes.
I sort of, wrongly or rightly, decided when I went to my first menopause conference that the word isn't getting out. So I thought, right, I'm going to play with the media and social media. And some of you might know I've plunked myself on the Ray and Kelly sofa a few times, and I've gone on the radio, and I'll talk to anyone that listens. And I work quite a lot with the media because it's really important to get the messaging right. And I get a lot of sort of, oh gosh, that can't be right, that can't be right. Well, actually, I'm a doctor. I need to sleep at night. I need to know the evidence. And so I think if we're persistent and consistent, then eventually people get fed up of listening, and they will listen because it's the same message. So I think what you're doing with the thrombosis charity is incredible. I think it's about more people saying the same things. Having joined up thinking is really powerful. And I think women like to talk, they like to share, so we can use on women's experiences and use women, and they will help each other. I think that's really powerful.
Very good. Jan, Ken?
I mean, I think we're actively working hard as the college to kind of, we know that vaccine uptake in certain populations is very low, and unfortunately it's the populations in whom the risk of COVID is higher. So I think that's true of the general population as well. And as Louise says, the need to use social media and to use the channels that patients are using, and in particular these risk groups, to target them and to promote sort of safety, and that there isn't a concern, because a lot of rumor goes around about vaccination causing problems with your fertility, vaccination causing problems for the baby, etc. And to try and dispel some of these embedded thoughts, I think, is very important. And yeah, the use of things like social media, sort of patient groups, reaching out to the ethnic groups in whom we really want to target vaccination has been a large amount of work for the college.
I think the other thing to say is actually asking the question. The number of times I've sat in an antenatal clinic in the past year, and nobody has ever said to me, without me actually saying to them, do you want to talk about the vaccine? Or do you want to talk about the risks of COVID and what you can do to try and minimize those? It's just spending 5 or 10 minutes understandably within a busy clinic, but it's just finding that little nugget of time to say, well, actually, this is something that's new and this is something that's changing, that we do actually need to get that message out there. And if the messages change, that isn't actually the end of the world. It's about being really transparent with patients to say, this is what we know now. It might change in the future, but this is where you can find the relevant information, guiding people towards appropriate websites like the RCOG, like Thrombosis UK, to say you can find what you want if it's a relevance to you in this location, and it will be updated and it will be peer reviewed and it will be, you know, exactly what it should be at that particular period in time. I think a lot of healthcare professionals feel that they can't say something if they don't know every single little bit about that particular area, but we never know that in medicine, particularly in areas like thrombosis, where the data are so muddy and unclear, that actually about being really open and transparent is the best way to practice, I think.
And what do we do about healthcare professionals? Because one of my commonest referrals is this woman wants to take HRT and she's had a clot, so she can't. What can she do? Louise, you've got to keep banging on, please, to healthcare professionals.
Yeah, it's very difficult because I've done a lot of work with the Royal College of GPs for many years, and I asked if I could give a free education programme to every GP practice and with them, and they said no, there's not enough in it to them, and that menopause management, there's too much diversity of opinion, and did I know that antidepressants work well for the hot flushes? So it's very exhausting, but some of you might know there's a programme documentary coming out on Channel 4 a week on Wednesday, so the 12th of May with Davina McCall, which is it's very, very good because it's all based on evidence. And so the charity is going to announce a bit more about what they're doing about education, because there's a lot of people want to know, you know, I certainly had no formal menopause training at all. And I'm sure most of you listening probably haven't. So it's really important that we get it in that's cheap and easy, because it actually is very easy. It's one of the easiest things that I prescribe. You know, it's very low risk. So we need to change the narrative. Instead of thinking, oh, can this woman go on HRT? We should be thinking, oh, why isn't she on HRT? And it will save so much money for the economy, actually, not just because women can get back to work, but also the amount of care. We know that £3 billion a year is spent on osteoporotic hip fractures. Look at dementia care, look at cardiovascular care in women. It goes on and on. So we've got to change it.
That's a point well made. Thank you. Does anyone else have anything else to say? We don't seem to have any more questions. I have to say that the three of you are outstanding at summarizing your data and presenting it extremely clearly. And normally we have people who overrun. You spoke well within your time. It was absolutely clear. And I have to commend the three of you for really entertaining us really well, and we've all learned something. So thank you very much. I hope you can perhaps come back next year and tell us where we are with all these topics. So thank you once again, and thank you too for Jo for organising it.